This is part 2 of the Nursing 242 podcast on fetal monitoring. So in part 1, we talked about a reactive and non-reactive non-stress test. So now we're going to talk about something called a contraction stress test. You guys will probably rarely see these being done in practice anymore. Kind of the general school of thought is if you were that concerned enough about the status of the fetus to do a contraction stress test, we probably should just induce labor. But there are still times and places where you'll see it happening, so you guys need to be aware of what it is. So what a contraction stress test is basically we're applying some stress to the fetus through contractions to see how the fetus responds to them. So it's going to record the response of the fetal heart rate to the stress of the contractions. So a fetus that has good oxygen reserves can tolerate the stress, or what we call the temporary hypoxia, that is induced by uterine contractions. So what we should see is the absence of fetal heart rate decelerations. So we're looking for a negative contraction stress test, meaning we don't see any late decelerations. We need to have at least 3 adequate, strong palpating uterine contractions in a 10-minute time frame. The fetal heart rate should have a normal baseline, and we should see fetal heart rate accelerations. So that's what we're looking for, a negative CST. A positive CST means that we see late decelerations with more than half of the uterine contractions. So here's an example of a negative CST, and it's also a reactive non-stress test, because you can see here where we have 1, 2, 3, 4 contractions in like a 7-minute time frame. So we have enough contractions, and we're not seeing any decelerations or dips in the fetal heart rate. And our baseline fetal heart rate here is about 130, and we're having beautiful accelerations that far exceed our 15 by 15 criteria. This is an example of a positive CST. So a positive CST is not good. We don't want to see this. So once again, we've got 4 contractions in this about a 7-minute chunk of tracing. Our fetal heart rate baseline is just a little below 120, like 118, I guess. But what we're seeing here, and we're going to go over these changes in just a minute, these are late decelerations here. All of these dips or changes in the fetal heart rate are what we call late decelerations. And they're happening with every contraction. And these are pretty worrisome. Late decelerations usually signify that there's some type of underlying issue with perfusion from the placenta. And we're going to talk about those in just a few more minutes. So, when a patient is in labor, so our intrapartum fetal assessment, we're going to talk about normal and abnormal patterns, internal versus external monitoring. Sometimes we'll use ultrasound. So when I talked about before, when we talked about indications and reasons to do a non-stress test and what we would do if we had one that was not reactive, ultrasound sometimes falls into that. We might do something called a biophysical profile, or a BPP, and we're going to talk about that in the intrapartum lecture. But basically, we're assessing the fetus with ultrasound. We're looking for fetal movement in utero. We're looking at the fluid level around the baby, just different things that we can take a look at to assess fetal status. And then we're going to talk about non-reassuring fetal heart rate patterns and what is our role, what are our nursing interventions that we're going to do if we see them. So we have a couple different kinds of what we call periodic changes or decelerations. There's earlies, lates, and variables, and then there are also prolonged decelerations. Okay, so here are your definitions of them. You guys can read through them. I want to show you the picture. It helps make it make a little bit more sense, and then on the slide after this you have our acronym, which is going to help you remember everything. So let's start first with early decelerations. So that's here in this first picture. So early decelerations are basically caused because of head compression. So basically it's almost like a vagal response. When there's a contraction, the head gets squeezed, causes the fetal heart rate to dip a little bit. So early decelerations are pretty gradual. They have a little gradual decrease in the fetal heart rate. They kind of go up slowly, they come up slowly. They are uniform with the contraction. They mirror the contraction. So what that means is if you find the peak of the contraction and you take your finger up on the fetal heart rate tracing, it usually mirrors the peak, or what we call the nadir, the lowest point of the deceleration. So the deceleration starts with a contraction, and typically it's going to end with a contraction. Starts with a contraction, ends with a contraction. They're really uniform in shape, so they go down gradually, they come up gradually. They typically do not dip down very deep, and they don't last very long. They usually just last during the contraction. Like I said, early decelerations are caused because of head compression. They are not worrisome. Okay, when we see early decelerations, we know it's a normal physiologic response. We don't need to do any other interventions. We just continue to assess and continue to monitor. Then we have late decelerations. The pathophysiology behind late decelerations is what we call uteroplacental insufficiency, which is a nice big fancy term for our placenta is not functioning the way it should and the baby is not getting adequately perfused through the placenta. So once again, they are a little similar to earlies in that they go down gradually, they come up gradually, they do not dip down really deep. Okay, earlies and lates, you can see they don't go down very deep. They usually don't dip below kind of a normal fetal heart rate baseline range. The way you know it's a late, you find the peak of the contraction, okay, take your finger up on the tracing. The deceleration starts after the peak of the contraction. Okay, so here's your peak, here's where the deceleration is starting. So they are late in onset. Okay. When we see late decelerations, this is when we really need to be thinking about our nursing interventions, okay? We're going to do something called intrauterine resuscitation. So usually the key steps in intrauterine resuscitation are going to be if the patient is on any type of induction or augmentation method, which is usually going to be IV, oxytocin, or Pitocin, you need to turn the Pitocin off. You don't want to be doing anything else that is going to cause stress to the fetus. And then the other things that we typically are going to do, change the patient's position, especially if she's laying flat on her back. You need to get her over, get her on her side, get her off of her back. We're going to give an IV fluid bolus. Usually that's going to be lactated ringers or normal saline because we want to help increase perfusion. And we're going to give oxygen. Now, typically what we're going to do, remember, these are an OB. These are young, healthy women. These are not, 80-year-old little old ladies that have COPD that you can over-oxygenate and kill their drive to breathe. These are young, healthy women. You really can't over-oxygenate them. What we give is typically 10 to 12 liters via face mask. Okay, so you're not given nasal cannula, you're not given 2 liters or 3 liters, you're going to do 10 to 12 liters via face mask. You do not need a physician's order or an advanced practice provider's order to do this. This would be no different from your patient having an MI in the middle of the hallway and falling down on the floor. You don't stop and say, I need to go get an order to start CPR on you, I'll be right back. Intrauterine resuscitation is essentially the same thing. You are essentially offering resuscitation to that baby in utero. Okay, so if the oxytocin is infusing, turn it off. Get that patient's position changed, IV fluid, O2. Okay, and we're going to assess this contraction pattern. If you do those things and we've had a few more contractions and this pattern persists, we need to notify the healthcare provider because this patient is probably going to need an urgent cesarean section for delivery. Some reasons we can see late deceleration. So we talked about the pathophysiology, uteroplacental insufficiency. Some of the reasons that can occur could be hypertension, could be diabetes, could be low blood pressure, so maybe even especially after an epidural is placed. Those are some examples of why we might see uteroplacental insufficiency. The next type of deceleration is a variable deceleration. So variables are just that. They are variable. They're variable in onset and shape, timing, all of that. Variables typically will happen with a contraction because the pathophys behind them is cord compression. The umbilical cord is getting squashed, but they can happen at any time. Sometimes what will happen is the baby will roll over and actually squash its own cord, which can cause a variable. So they can happen in the absence of contractions. They typically are going to happen during a contraction though, but they can happen after a contraction. They can be almost late in timing. So the way you're going to know it's a variable and not an early or a late deceleration is how abrupt they are and how deep they are. Variable decelerations are typically going to be V-shaped, or they're going to be U or W-shaped. So you can see how they go down really quickly and they go down deep, but they also come back up very quickly. So if you compare this to earlies and lates, you can see how these are subtle. They go down really slowly, they come up slowly, they don't dip down really deep, where variables do. Okay, they go down really quickly, they come up really quickly, and they can drop really, really deep. They can drop down sometimes to the 60s or even further than that. So variable decelerations, pathophysiology behind them is typically going to be cord compression. So nursing interventions, you can still do your intrauterine resuscitation, but the most important thing you need to do is change the mother's position, because if you change mom's position, it may help alleviate some of that stress or pressure on the umbilical cord. Variable decelerations of in themselves are not terribly worrisome, especially if the tracing otherwise looks good. We have accelerations, or we have that moderate or average long-term variability that we talked about before. So usually it's something we continue to assess. Now, if they're starting to become repetitive with every contraction and they're getting deeper and they're lasting for longer periods of time, then they could potentially be something a little more worrisome. So there's a helpful acronym that you guys can use to remember the types of periodic changes that we see in the pathophysiology behind them, and it's VLCHOP. So variables, earlies, accelerations, and late decelerations, and then the corresponding pathophysiology behind them. So for variables, it's cord compression. For earlies, it's head compression. Accelerations are okay, or they mean good oxygenation. And lates is placental insufficiency. So here are some examples. This here is an example of early deceleration. So whenever you're uncertain, you find that peak of the contraction, go up. See how the peak of the contraction mirrors the nadir or the lowest dip of the deceleration. See how they're really subtle. These are not variables. They don't dip down really deep. They go down gradually. They come up gradually. Okay, so there's one here, and one here. So we don't really need to do any interventions with this. We just continue to monitor and assess. Example of late deceleration. So find that peak of the contraction, go straight up. That's where the deceleration starts. So find the peak of the contraction, go straight up. That's when the deceleration starts. You can see that we have this repetitive pattern of having a late deceleration here with every single contraction. So this is worrisome. We also, have minimal variability as well. We have no acceleration. So this whole pattern of in itself is very worrisome. So nursing interventions, we can do all those things we talked about. If she's got oxytocin running, better turn it off, turn the pit off. Get some O2 on her, change her position, give her an IV fluid bolus, and notify the healthcare provider. You want to remember in nursing, notifying the healthcare provider is almost never going to be your first action. There's almost always going to be something that you as a nurse should do prior to notifying the healthcare provider. And if this pattern does not resolve itself quickly with your nursing interventions, you need to anticipate and begin preparing for a cesarean section. Then we have variable decelerations. So I'm going to show you a couple different examples here. So this is where they're occurring with the contractions. You can see here, and actually these spiky things here in the contractions, basically what's happening here is the patient is pushing. So that's why you're seeing these spikes here. So once again, these are caused from cord compression. These are a little more worrisome because these are really, really deep, and you can see in between them we've got some fetal tachycardia. These are going down deeper and they're lasting longer. Nursing interventions, once again, change mom's position. That's the first thing you want to try to do. You can give her some oxygen, give her a fluid bolus. Certainly if she's got oxytocin running, turn it off. So here's another example of variable decelerations. When students see this, they assume they're late because they look here and say, okay, here's the peak of the contraction, there's the variable, here's the peak of the contraction, here's the variable. So they think they're late. These are not lates, these are variables. They're variables because of they're V-shaped and they're very abrupt and they're very deep. Late decelerations do not look like this. Then sometimes we can see a prolonged fetal heart rate deceleration. A lot of times when we see these, they tend to be after an epidural is placed. What we're going to talk about in the intrapartum lecture is some of the common side effects of an epidural, and one of them is maternal hypotension, which can cause a prolonged fetal heart rate deceleration. So we want to make sure, certainly we've assessed mom's blood pressure if this happens, so we can make sure that that's not the cause. We want to treat any underlying causes of this. So if this is a one-time incident and this occurs, typically the first thing we're going to do is, start doing that intrauterine resuscitation. So first thing, get that mom repositioned, get her off of her back because we don't know why she's having the deceleration. Is it a perfusion issue? Is it initially starting because a cord gets compressed? We don't really know. So reposition her, give her an IV fluid bolus, get oxygen on her. If she's got oxytocin running, of course, turn it off. And we want to notify the healthcare provider. If this pattern resolves itself, which it looks like it is doing here towards the end of this tracing, then it's something that we'll continue to watch and monitor. One episode of this does not necessarily mean a patient's going to emergently end up in the operating room for a cesarean section, but certainly if this is something that happens 2, 3, or more times, then this is a patient who also would end up needing a cesarean section. Here's an example of the NICHD terminology that I was telling you guys a little bit about in part 1 of the podcast. There is a good handout of this in your packet that goes through this in more detail, and it's a little bit of a bigger printout so you can read it easier. But a lot of times you will see in the hospital fetal heart rate tracings will be labeled category 1, category 2, category 3. And it's just a really quick assessment of the overall pattern of the fetal heart rate and how the fetus is doing. Typically what we're going to be seeing are category 1 fetal heart rates. Those are what we want to see. So there's a direct association between a category 1 pattern and a normal fetal outcome. So these are those tracings that are normal. Okay, we have normal baseline. We have a moderate variability. We don't have late decelerations. We don't have variables or prolonged decelerations. When we get into category 2 tracings, those are the ones that can kind of be questionable. They're falling kind of into that gray zone of we're seeing some good things that we like, but we're also seeing some things that are giving us some concerns and some worries. So they don't always directly correlate with poor fetal outcomes, but they can correlate with some poor fetal outcomes. So those are the tracings that are going to be watched very closely. Category 3 tracings typically require an urgent or emergent cesarean section. So these are going to be patterns where we're seeing things like recurrent late decelerations, those recurrent deep variable decelerations, bradycardia, sinusoidal patterns. So those are things that require prompt treatment and intervention. So we're going to talk about internal monitoring now. So reasons we might do internal fetal monitoring. So anytime we need to get a better reading or a better picture from what the external monitor is providing us. Sometimes we see it needing to be used, especially in our clients who are obese or morbidly obese, because it can be very difficult and challenging to monitor them externally. Now that does not mean because someone falls into the obese category, we automatically put internal monitors on them. Of course, we always try to monitor a patient externally first, but when those methods fail, we may need to move to internal monitoring. Other reasons might be a patient maybe who's having a trial of labor after a previous cesarean section, so we want to really have a good picture of what's going on with her uterine activity or the fetus. We might also do them if we have somebody who, let's say she has an epidural and can't tell us how uncomfortable her contractions are, and we are palpating them and they feel like they're strong, but her cervix isn't changing and we're not sure what's going on. We might put one in to really give us a good reading of what her contractions are doing. The risk of internal monitoring is obviously infection, both for mom and baby. Client must also need to have ruptured membranes. For benefits, we will have better monitoring of the fetus, better monitoring of uterine activity. We might be able to give the patient a better chance of a vaginal birth depending on what's going on. Another possibility would be if a patient has an IUPC or an intrauterine pressure catheter, which we're going to get to that in just a minute, we may also be able to do something called an amnio infusion. So for those patients that are having those deep variable decelerations, they're happening because cord compression. So sometimes if we replace some fluid back into the uterus, it can help with the cushioning of the umbilical cord and decrease those variable decelerations. So sometimes we will do that. That's called an amnio infusion. We want to be careful, though, when we do internal monitoring. We talk about something in OB called the cascade of interventions. And basically what that is every time we do one intervention, it increases the risk of more and more and more and more intervention needing to be done. So for instance, a patient, a lot of times the first intervention in labor is an epidural. So a patient gets an epidural, might slow down her labor a little bit. So then maybe we need to give her some oxytocin to increase her labor, or maybe we have to rupture her membranes. Well, now we've increased her risk of infection. Because she has an epidural, she can't feel to pee, so now we have to put a catheter in her. That increases her risk of infection. She may be more likely now to need assisted delivery with forceps, vacuum, or C-section. So every time we go messing around with the normal course of labor, there is a chance for needing more and more intervention as we go. Other risks associated with internal monitoring, especially the fetal scalp electrode, which is the next slide here. Fetal scalp electrode not only increases risk of infection for mom and baby, but you want to think more specifically. What we're doing with a fetal scalp electrode is it's a little corkscrew that essentially goes right under the fetal scalp. So not only are we leaving something in the woman's body that could potentially be a portal for infection, we're also causing a puncture in the fetal head. So we never, ever, ever want to use a fetal scalp electrode on women who are HIV positive or if they are hepatitis B positive, because now we've greatly increased the risk of transmission of those viruses to the fetus. I will show you guys an example in the classroom so you can see what these look like and be able to actually feel them and touch them and look at them up close. But this kind of gives you an example. So what happens is the healthcare provider applies the electrode on the fetal head, obviously not over one of the fontanelles. It has to be over a bony prominence. And the little electrode goes under the skin. There is a cord then that will be essentially hanging out of the vagina. It gets attached to the fetal monitor. So the fetal scalp electrode is nice because it gives us a beat-to-beat reading of the fetal heart rate. So if mom changes position, baby moves, shifts, we typically are not going to lose the tracing at all like we might with an external monitor. So after delivery, when this is removed, it is going to leave a small scab on the baby's head. So we need to explain that to our patients so they know what to expect. Then we have the IUPC, or an intrauterine pressure catheter. I also will pass some of these out in the classroom so you guys can see them, see what they look like. IUPC is a pressure catheter that gets inserted between the wall of the uterus and the baby. And what it does is it gives us a reading in millimeters of mercury for each contraction that the patient has. So it can be really helpful for us if we have a patient whose labor has stalled and we're trying to determine if her contractions are strong enough and adequate enough that they should be causing cervical change. So certainly, once again, this is going to increase the risk of infection for both mom and baby. We can give an amnio infusion. So I'll show you guys when I pass these around in the classroom. If we go back to the previous picture, on these pressure catheters, this is the part that gets hooked up to the fetal monitor. But here you can see this is the cap for it. There is a port right here, an IV port, where we can hook up IV fluids to be put into the uterus to help replace some of that fluid if we think an amnio infusion might be warranted. So the patient, once again, will need to have ruptured membranes to have this intrauterine pressure catheter inserted. Now, a patient could have a combination of internal and external monitors. So the long and the short of it is they need one way to monitor the fetal heart rate. That could be external, it could be internal. We need one way to monitor uterine contractions. Could be external, could be internal. So sometimes what you'll see is the patient may have the TOCO, or the external monitor for contractions, on, but they have an internal monitor for fetal heart rate. So just because you have one internal doesn't mean they both need to be internal monitors. So the next couple of tracings, and we're going to do this in the classroom, we'll go over this and discuss this, but you guys can look at these in the meantime, is look at these next couple of slides of the fetal heart rate tracings. Try to determine the baseline fetal heart rate and variability. So take a look at these on your own. Look at the contraction pattern. You know, how often are the contractions coming? How long are they lasting? Do you see periodic changes? Do you see accelerations, decelerations? If you see decelerations, what type are they? And what, if any, nursing interventions are needed for these particular fetal heart rate tracings? And like I said, we will discuss them in the classroom and go over them. And that will be the end of part 2 of the fetal heart rate monitoring podcast for Nursing 242.